Welcome to this edition of Innovative Conversations, brought to you by the Center for Innovative Practices at the Begun Center for Violence Prevention, Research, and Education at Case Western Reserve University. This podcast is supported by the Ohio Department of Mental Health and Addiction Services. I'm your host, Patrick Kanary, for today's conversation. Today's topic continues our look at services and supports within a system of care for youth families with behavioral health needs. We will be taking a big picture look at mobile response and stabilization services, hereafter referred to as MRSS, because I'll only be able to say that once as your host. So we're going to go to the abbreviation. You'll find more details on MRSS in the articles and the links that'll be posted with this podcast webcast, along with information on today's guests, more detail that I'm going to give you when I introduce them. And our website is www.ihbtohio.org. Again, www.ihbtohio.org. We're really fortunate to have 4 exceptional guests for this conversation. And we'd go way over time if I tried to give them their full due in terms of introductions. So I'm going to be brief and urge you to look at their bio sketches that are posted on the site. I think you'll be as impressed as I am with their knowledge and scope regarding MRSS and all things system of care. So Rick Scheffler is the director of the Center for Innovative Practices, and he's been working closely with state, local, and national partners to look at the implementation of MRSS in our fair state of Ohio here, where we're broadcasting from. Elizabeth Manley is a clinical instructor for health and behavioral health policy at the Institute for Innovation and Implementation. Liz provides technical assistance to states and communities specific to children's behavioral health innovations with a specific focus on policy and financing of systems of care. She's the former Assistant Commissioner for the state of New Jersey's Children's System of Care. Christopher Morano has been a licensed psychologist for nearly 30 years. He has been the past director of Emergency Mobile Mental Health Services for Milwaukee County Children and Families, with responsibilities for including management of inpatient care needs for both high-risk youth, and he is currently consults with local mental health agencies on the needs of children and their families. And finally, Jeffrey Vanderploeg, okay, that's going to be bad. we may need to edit that. Is the president and CEO of the Child Health and Development Institute, a nonprofit organization in Farmington, Connecticut, as well as its parent organization, the Children's Fund of Connecticut, a public charitable foundation. The mission of CHDI is to advance effective policies and practices in 2 main areas of work: children's behavioral health and pediatric primary and prevention healthcare. So Jeffrey, with apologies to your name. So welcome to all of you, and thanks so much for being a part of this discussion. I should say that this is going to be part 1 of a 2-part podcast conversation on MRSS. The next one will be focused very specifically on what's happening in Ohio. So today's intent is really to kind of give you kind of the big picture overview and the introduction, if you will, for some of you who may need that. So I'm going to start off by turning to Liz and Chris to help us set the stage by giving us a, I say definition of MRSS, and I know it's not a hard and fast, but if you could give us that kind of definition. And Chris, I know that you're going to add a little bit of information also around the wraparound Milwaukee focus for MRSS. So go ahead, you two. Anxious to hear what you have to say.
Thank you, Patrick. I'll get started, and then I'm sure Chris can share with us his experiences, which I think are really important to hear from. So there's a core group of states that have been doing a ton of work around meeting the urgency that families experience when a child is beginning to experience a behavioral health challenge. And that core group of states includes states like Connecticut, New Jersey, Oklahoma, Nevada, certainly wraparound Milwaukee, who started a lot of this work. And there's some core principles around what we believe are important for states and communities to consider when you are thinking specifically about children and families and their needs when a child is experiencing a crisis. The first thing to think about from our perspective is that the crisis is not just the child. The crisis is the families. It's usually picked up initially by a parent, sometimes by a teacher or a pediatrician. So it's an adult who's identifying that a child is experiencing some stress and demonstrating some change in their behavior. And so the first part of mobile response and stabilization, or MRSS, is that the crisis is really defined by the parent or the caregiver and not by someone else, right? So the formal child serving system does not define the crisis. And the reason for that is parents really begin to perceive something is happening and may not know what to do about it earlier than the system would perceive that. And recognizing the parent's anxiety is also part of what we're working very hard to address early. And recognizing that we can do that in a way that makes a lot of sense in terms of addressing the parent's sense of urgency, the system's challenges around that, getting a good assessment, and really being able to keep children in their homes and their communities. So the first core component is the crisis is defined by the parent or caregiver. The second core principle that we've come to some agreement on is that mobile response is an in-person delivered service. It's not over the phone, and it's not families are not triaged out. They're not, when someone calls for help, we send the help. Parent calls, the team responds, and they respond whether that 15-year-old won't get off the sofa or whether there's a child who's throwing a chair, right? The crisis is the same because the family is telling us it's the same. And so when that call comes in, the team goes. And that there's not just a crisis response in that 72-hour period. It is also connected to some type of stabilization services, which are interconnected in the work that they do, which is really important, not just to stabilize a crisis situation and help the family understand what's going on, reestablishing communication with that young person and the family, but it's also about reconnecting that young person into the activities that they were engaged with before the ties are severed, before the child has done damage to those relationships. We want to reestablish those relationships before things go too far down the path. I'll give you a quick example. It takes parents, when parents begin to see that things are happening or there's a crisis happening for a young person, when they begin to perceive that versus when they actually get some kind of help, can be up to 2 years. If you can reduce that time frame to a very short period of time, you can reestablish those connections and help those people who are really important in that young person's life and in the family's life. You can help them understand exactly what's going on with that young person. So not only are you not isolating the child, you're not isolating the family either, which are really core components within the MRSS world. Another real important idea around this is that there's a good assessment that happens, right? So there's the assessment, a common assessment tool that's used. Some states use the CANS tool, the Child and Adolescent Needs and Strengths tool developed by John Lyons. Some use other tools, and I should say they use a form of that tool, the CANS, used commonly referred to as the crisis assessment tool. But there's a common assessment tool that's used across the full population of individuals within a community that are using that particular service, are really important core components. And then the other real important thing to remember is that the goal of mobile response or MRSS is not necessarily to connect that young person with a formal intervention. It is about reestablishing and connecting that young person with community, ensuring that they go back to school, making sure there's core connections to their health care and making sure they're connected to the pediatrician, making sure that there are adults who are back in that child's life who can help proceed to move them forward. And additionally, it's important to connect that young person to any formal supports or formal supports that might be necessary, identify whether or not there's a moderate or complex behavioral health need in it, you know, and establish some connection to the next steps. Those are all really core components within the mobile response and stabilization.
Thanks. That's a lot, and we're going to unpack various pieces and parts of that as we discuss. So, Chris, do you want to kind of illuminate from a more focused perspective in terms of a site from your experience?
Sure, and I really appreciate Liz's comments, especially about the core principles, which we all pretty much agree on. Specifically, early intervention is vital as early as possible. It's never too late to help a child or an adolescent, but early intervention is key, and focusing on the family. And that's really just to segue how we began to think about it in Milwaukee, Wisconsin, over 25 years ago. Now, I've been across the country helping teams and training systems on how to do mobile response support. It's Tuesday, so this must be Vegas. I'm in Vegas now, but I started Milwaukee's team with another gentleman in 1994. And ironically, it was in the wake of a lawsuit where the county was litigated successfully and had to come up with a broader array of responses to kids who had trouble besides psychiatric inpatient care. So at that time, it was really laser focused on, at least at the beginning, reducing inpatient psychiatric use. And that became one of my primary responsibilities as a director, was to gatekeep psychiatric inpatient care. So Milwaukee didn't come up with the idea of doing mobile crisis intervention in the community. It had been done in places like Alaska, all over the place. But we were quite successful at reducing not only the number of hospital beds for children with complex needs and inpatient stays and creating alternatives in the community, but reducing lengths of stay. So the grabby part of it was that we took a 144-bed public hospital unit just for children and reduced it to a 12-bed unit by the time I left. And that got people's attention and sort of got us on the map and got a lot of folks talking about this. And at the time, it was called Mobile Crisis, and we don't do that anymore. Several years ago, I started a chorus of folks to get this idea that to focus on crisis would do a number of things that we wanted to avoid. It would create a sort of a reactive approach that we didn't want. So, and it also created a reaction within staff and families that they call during a crisis and they have to respond to a crisis. We wanted to change the focus, and we did that. And now from SAMHSA on down, we talk about mobile response support systems and stabilization systems. And that is just a great advance in what we do. But we, gradually developed it as it's a strategy. It's on a continuum of care. It's not a therapy per se, but it's a strategy on a continuum of care that should be available to everybody, every child and family in need. And it's never too late to help a child. So I've had quite a number of experiences where we've worked with adolescents. I'm still on the ground coaching here in Vegas, and we talk to teenagers every week who struggle with this. And we want it to be a mobile face-to-face community response system, but we recognize the impact of the virtual world, which is unavoidable at this time. And we'll get more into that later, but really it started out as an effort to create alternatives to traditional intensive, resource-intensive care, and we did a quite effective job of it. So it transformed into something even more broadly applied now, which is mobile response and stabilization services. And I'm very glad to be a part of it.
Great, great. So Jeff, I'm wondering if you could take us like just to another level as well and talk a little bit more, both Liz and Chris reference this, but a little bit more specifically about some of the key practice elements and what settings are we finding MRSS being implemented?
Yeah, so thanks, Patrick. So much of what Liz and Chris both talked about already has a lot of relevance to how MRSS rolls out in practice. The first thing I would note is that this is a following up on Liz's comment, is that the child MRSS model differs pretty distinctly from an adult-based model. It's stronger on prevention. It's stronger on early identification of risk and early intervention, whereas many adult models might serve adults with chronic or severe conditions. MRSS for the child serving system is really more about identifying issues early and intervening early. I'd say another key feature of MRSS for kids is that it does tend to be more mobile as well. Again, kind of thinking about some contrast with the adult models, many times the adult models might aim for 50% mobility. In many systems for children, mobility expectations are much, much higher. In our model in Connecticut, our expectation for providers is 90% mobility, for example. And then I think some other things that are just common to all child serving services of any kind, really, when it comes to practice considerations. There's certainly a much stronger family involvement in child-focused MRSS. A lot of adult work might be done individually, but child work really, as we all know, can't be done well without family involvement. And then there's also the element of cross systems. So, a very basic example would be schools. In our system in Connecticut, again, the number one referrer to our mobile program is actually the school system. So inevitably, you're interacting with multiple child interfacing systems. And so that's an important part of doing the work as well, and kind of speak to really the values and principles of mobile response. Another thing that I would say is that, picking up on the point about crisis being defined by caller, one of the best practices that we see out there for MRSS is that the referral threshold tends to be very low. As people were noting earlier, there's not as much triaging and saying, this doesn't meet my definition of a crisis, or doesn't require an in-person response. The best practice in mobile response for children is to keep that referral threshold low, meaning if you define it as a crisis, then we are willing to come out as a provider and respond to that. So there's very little triaging and lots of mobility and a high premium placed on accessibility of mobile response services. Another thing I would note is this, it's related to the point I just made, and it has to go with what we refer to in Connecticut in our program as the just go mentality. So I have an example here. It's I remember early on in the redesign of our system about 12 years ago that I had a provider ask me, well, what happens if a school calls and then the parent refuses? And this was one of dozens of examples of, well, what if this or what if that? And almost inevitably my answer was just go. But this one actually struck me as really an important example. Certainly, if a parent actively refuses to provide consent for mobile response to interact with their child, then you shouldn't do it. But our advice to the provider was go to the school anyways and talk to the school personnel at least, because you've now made a connection with the adult decision makers in that school system where they're going to view you as a resource in the community that will respond to them and be able to meet their needs. So even if you don't lay eyes clinically on that student today, you will have made a positive connection, and then the next time they have a need, they'll be much more willing to respond to you because you've really demonstrated your value as a resource in the system. So those are a few things that come to mind. There are some other nuances to providing mobile services that I think this group will be well equipped to speak to. Most programs, for example, are 24/7 mobility these days, or at least have some kind of call answering mechanism during the overnight hours and the ability to respond first thing in the morning in person. And a last point I would say before I turn it back to you, because there's a lot that can be said, and I'm sure will be said today, is that one of the really unique features I think of mobile response is that it's, call it transdiagnostic. So the clinicians have to have a lot of skills, because you're not just responding to kids with anxiety conditions who have a need for mobile response. You're responding to kids who have anxiety issues, depression, suicidality, maybe even obsessive compulsive behaviors, trauma exposure. There's a whole range of diagnostic issues going on for the population of youth that use mobile response, which I think creates a lot of a variety and interest for the clinicians who provide the service, but there's also the challenge of having the skills to be able to address a number of different clinical needs.
Yeah, and I think that, you know, in doing just, you know, my own initial dive into this, thanks to all of the good information you all sent me, that notion of where it fits, how, like you said, kind of trans-systemic it is really key. Rick, I wanted you to jump in here just for a minute before we talk about implementation, because you're the Ohio person on this conversation, or in this conversation. And I'm wondering if this conversation so far is mapping with where Ohio's thinking is. And again, I know our second podcast is really going to be, you know, much more detailed in Ohio, but I just wanted to get your impression about the zone that Ohio is in regarding MRSS.
Yeah, Patrick, thank you. You know, I think what we're doing in Ohio maps almost identically to what Liz and Chris and Jeff talked about. They were some of our main trainers, and nationally they are the experts. And so, you know, we followed their lead. You know, what we've paid attention to was not only that first part, but also a lot of the 4 weeks, you know, stabilization period that follows. And so we spent a lot of time developing, you know, specific skill parts that we'll teach to youth and families and parents. And then how do we also, we took a dive into how do we make sure that the family that we're serving has some sort of a child and family team meeting before we let go. So that if they're not already linked, that they would have some sort of a planning process that follows them once we're done. And I know a lot of the other folks are doing something similar to that. So, and the other thing that, our project director, Wilma Townsend, has really addressed is integrating youth and family peer support, or parent peer support into the model very intentionally as a part of the team. And again, I don't know that this is any different than the other models that were just presented, but that's our focus right now. And we are truly, fledgling at this point, and still developing.
Okay. Thanks. I appreciate that. I just wanted to kind of get a little bit of that perspective, and we'll probably do that again a couple of times as we move forward. Chris, I wanted to kind of focus this question at you, but again, all of you who have comments, please jump in. But, I think for those of us who have been around implementing, developing services within a system of care, we know that even really great services live and die by implementation. And I'm wondering if you could just give us a little more information about what the challenges are with implementing MRSS. I know that's like a big question, but I really think that sometimes it's an area, well, fortunately, it's an area where I think we're paying a lot more attention to than we used to. And so I'm wondering, from an MRSS perspective, what have been some of the challenges of implementation?
That's a great question, Patrick. And, I'm fond of saying that, the roadmap and the road often look very different. You can create a system on paper. You can create a plan for a family on paper or in a vacuum, and then when it's played out, it's much different. The challenges once you actually really impart this kind of a system or any specific clinical intervention are unexpected and great. So that's one of them. You just never know what to expect here. Another challenge is buy-in. You've got to get your community members, other providers from more traditional sources of support to buy into what you're doing. And if you don't get that, it can sink it. It can sink the whole operation. I know that was a focus in Milwaukee. We were eventually successful at getting the support, garnering the actual financial support, speaking of sustainability, of not only the child welfare system, but the juvenile justice system. And so we had pooled funding, not just for the wraparound program, but for the mobile response team. So you've got to get buy-in from your community, which is immense. Another thing that has been highlighted, unfortunately, with COVID, is the health, not only the physical health, but the mental and emotional well-being of your staff and your providers. For the first time since 9/11, and probably in a more expansive and broad way, the helpers, the healers, have found themselves to be in the same quandary, the same challenge, the same trauma as the people they're trying to help. Yeah. So it's really put a spotlight on how important it is for staff to be supported and staff to have recovery and resilience opportunities within a system. Very often, larger agencies that mobile response teams are embedded within will say that they're trauma-informed, and in fact they might be, but it goes far beyond just having a day of support and 10-minute chair massages for your staff. You've got to do it as a routine. You've got to build it in to your daily rituals with your staff, because it's that important. More than anything else, what I think mobile response teams and formerly mobile crisis teams brought out was that this is an emotional work. It's far different than doing outpatient office-based therapy, which has a place in the continuum of care as well, and is as valuable as anything else. This work is very often a challenge attacks on the staff themselves, because you've got families who are at their most vulnerable, letting you in to their homes and the places that they live. And that creates opportunities for staff to react and grow themselves. And more than many other therapeutic strategies, it's incumbent upon the staff to be balanced, emotionally strong, and clear. I'll give you an example. I worked with a team here last week, and we had a 12-year-old girl who was suicidal, and mom was beside herself and emotional and fracturing right in front of us. It was a virtual intervention. And the staff is a great staff. She's a therapist, but she was paralyzed just with mom's emotion. I was more active in that coaching instance than usual, but we had to sort through a lot. And the reaction it brings about in staff members and providers can be unexpected and should be planned for and prepared for. So those are just some of the challenges that we face. And now I think coming out of COVID at some point, I'm not a soothsayer, but I would hazard to guess that we're not going to just simply return to how things are being done and be completely mobile again, despite my strong desire to do that. So another challenge is going to be how to interact with families, engage families in a virtual world, at least a little bit more.
Right.
I know that my colleagues have other challenges that they can see. Sustainability is one. Jeff and Liz can talk about that more, but it's an obvious one.
Yeah, a couple other things. Sorry, go ahead, please.
Go ahead, Liz.
So I think, other implementation challenges really are when, at least my experience are, when states are already doing mobile crisis in an adult world, an adult model, and transitioning from that, really understanding the difference between adult and children. There's a lot of differences, and it takes a lot to train the workforce around what those differences are. Sometimes around leadership and around policy are important around that, and they are distinct models with distinct needs, and really, really different points of view, including the issue of no triage, right? The triage is getting more information about the family. It is not whether or not we're going to go, right? As Jeff said, we're going to go. So shifting that workforce, shifting the community around who sits at the table, right? And making sure partners are available. Chris talked about child welfare. I just wanted to share one quick example about child welfare from New Jersey. New Jersey uses mobile response and stabilization for all children who are removed from their homes because of concerns about abuse and neglect and placed in the foster home to help ease access into that home. It helps both the foster parent understand what potentially is going on, helps the young person understand the physical symptoms of trauma and what they might experience and what it might look like, and helps to really stabilize that first place that young person went. In the pilot in New Jersey, 46 out of 46 youth stabilized in the first home they went in with 0 behavioral moves. Really important concept around that. And then I think the other part of it is really oriented to community resources, right? And making sure that this is not just about clinicians making referrals. Because if it's just clinicians making referrals, it's really, you get there faster, but you haven't really changed the trend. And this is really about keeping young people engaged in their community. And so we need to really bring the community to them, including making sure that law enforcement is engaged in this conversation about when to call, how to be a resource, and how to hand off. Pediatricians, how they're going to be part of this conversation, how the schools are going to be part of this conversation, to really think about young people in a very different way.
Yeah. One thing that stood out for me in your comments there, is this notion that, and I think it's going to come up again in the question I'm going to ask Jeff about kind of the inner system piece of it. But there's an opportunity here as well for this type of service to help address outcomes in other child-serving systems. And I think that goes back to Chris's comment about partnerships. And I think part of it is showing your partners that there's a reason to be a partner aside from let's be good colleagues and collaborate, but because we can help you and vice versa. Meet some of the goals that your system is trying to address, like keeping kids out of placement and reducing the number of placements if you're in a foster home situation. So, I think that was really key.
Patrick, would you mind?
Something here? Go ahead.
Yeah, let me add just 2 other things. I agree with everything that was said about back to your original question about implementation challenges. I just wanted to add two more, and they both, in my mind at least, fit under the broad category of managing expectations. And so the first thing I would say is in that would be oftentimes what we find is that when folks out in the community think about a mobile response, I think the vision that they have in their head is a police car or an ambulance. And so in the midst of a behavioral crisis, even a 30-minute response time feels like an eternity to people. And, there aren't many or perhaps any other programs that would be able to get to you 30 minutes after you call, but it's still that notion of managing the expectation about what mobile is able to do. It's not going to be there in 90 seconds like the fire truck or the ambulance, but it's going to be there in 20 or 30 or 40 minutes and it will be able to help you to manage that situation. And then the second example under managing expectations would be that oftentimes, I think one of the implementation challenges can be that what folks are expecting to come out of the mobile response. Remember that mobile comes very strongly out of this system of care tradition, and there's a high premium, again, placed on this notion of keeping children in their homes, schools, and communities. And I think what happens sometimes is that when people particularly people who may not be familiar with mobile already, they may have an expectation that you're going to take this child and you're going to bring them to the emergency department or get them an inpatient hospitalization bed. And I think managing that expectation in the community is also very important, because that's really not what mobile is set up to be able to do.
Mm-hmm. Yeah, good points. Good points. If you could maybe continue a little bit more along those lines. We've referenced the fact that there's a system of care framework here. There's an inter-system framework. There's a collaborative framework. That MRSS is not a kind of standalone service. And I'm wondering, Jeff, if you could talk just a little bit about some of the, not necessarily challenges, but I'll say challenges, but also opportunities in working with other systems and where the connection gets made with MRSS.
Sure, I'll get it started. I know that my colleagues on the call have a lot more to say about this particular point as well, but for me, it goes back into the point about where does MRSS fit within a broader system of care. And I would say one of the core features of the initiative or the program is that it provides a timely alternative or a diversion from more costly and more restrictive settings. And so let me just give you a few examples. Foster care, removal from the home or foster care placement. New Jersey has done an excellent job, for example, of creating a requirement that in the event of any child removal from the home, that a visit from a mobile response provider is a requirement. And I think the point of all that is to establish a connection with a mobile responder, because we know that one of the number one reasons for placement disruption out of foster care, for example, is behavioral challenges for children in foster care. So making that connection to mobile response can create a really important connection to a provider community that helps stabilize, in the unfortunate event of a removal of a child from the home and placement in foster care. A second area where I think mobile crosses over into other systems is if you have a really robust mobile system that's able to intersect with your juvenile justice system, you have a real opportunity to leverage your mobile system to not only address emergent behavioral health needs, but you can also use it to divert youth who might otherwise be arrested and enter into the juvenile justice system. And we have a great program in Connecticut where we've been able to leverage our mobile service system to reduce the number of youth who are being arrested in schools, kind of that what was commonly referred to as the school to prison pipeline. Mm-hmm. A third area that I think is an important crossover for a mobile in sort of the broad child serving systems is the emergency department and the hospital system. We have Connecticut, like every other state in the country right now, is experiencing an upsurge in the number of children with behavioral health needs who are showing up to emergency departments in crisis. And I think that stems from either the sheer lack of community-based resources or perhaps just a lack of awareness around what alternatives exist. And if you think about sort of the decision making that takes place for a family member or a school teacher or administrator in that moment of a really challenging behavioral situation, they need somebody to be able to respond to the needs of that child right away. And in places that may not have a mobile service system that can respond quickly, the emergency department might be the first place that they think of to take children, because they don't turn kids away and they're immediately available. And I don't want to be too glib about this, but I think there are also situations in schools, for example, where they say, you know what, I've got 22 other kids in this classroom and I'm trying to teach a lesson, and right now I just need this child to be out of my hair. And there is an element of that, and I think there's school systems who do it well and really try to keep kids engaged, but then I think there's also some situations in schools where I think removal and exclusion from the academic environment can be a real powerful motivator, and mobile can help step into that as well. Those are just some examples of how mobile might cross into other systems. And I think that mobile plays a really important role in linkages and outreach and education about what's available to each of these system actors, if you will, and how mobile can meet their needs. So it's not uncommon at all. In fact, in our Connecticut system, we require all of our mobile providers to engage in at least 2, and frequently many more than that, outreach activities every single month. that might be community fairs, health fairs, visiting a school, or going to a back to school event. Anything out there in the community where they can literally go, set up a table, put out the mobile chip clips and pens and stress balls, and just educate people about the availability of MRSS and what they can provide to them in the system. And I think that's an important role that mobile plays in the community as well.
Great, great. Liz, I was wondering if you could comment briefly just a little bit on the financing piece.
Sure.
I know that some of your consulting work has been around Medicaid and financing, and just kind of give us a snapshot of what that might look like or does look like in various places.
Yeah, absolutely. So let's start with the idea that in 2013, SAMHSA and CMS, the Medicaid and Medicare Services folks, sent a letter to the children's behavioral health directors across the country and said, in this service array, we believe that mobile, at that time they called it mobile crisis services, should be included, right? It should be one of the core elements in your Medicaid plan for children, specifically for children. You know, and I was in New Jersey as the children's behavioral health director at that time, the assistant commissioner. And when I received that, and I thought, wow, we're finally catching up. So New Jersey had mobile response and stabilization in its service array, and had taken a really important stand in saying that this is a total population service. In other words, any parent can call and we're going to send help, which is really, I think, the direction that SAMHSA is hoping that states will consider, right? Putting resources into children who are underinsured or not insured at all, and really provide this service. But it is a core component within the Medicaid service array that most states are at least considering if they don't already have it in their service array. And it makes a huge difference in the long term around what other services you're paying for, right? Because to Jeff's point, if you're keeping children out of emergency departments, out of inpatient care, if you're reducing residential stays, if you are reducing the number of moves in foster care. Quick other example, New Jersey has one of the lowest rates of children in foster care who are on psychotropic medication, a big expense within a Medicaid plan, right? And so, and part of that is because you're addressing the things that cause those moves to happen by using this upstream intervention that is really cost effective when you think about it in those terms. It is covered right now in Medicaid across the board, so any state can begin to think about how to put it in their Medicaid plan. Many states are beginning to think about how to bring commercial insurers into this conversation as payers. Commercial insurers, the number one thing that they pay for are that inpatient and residential services. I mean, mostly inpatient and emergency department visits are what commercial insurers are paying for. And on top of that, you know, we can reduce some of the services that are not demonstrating that children get better, right? Things like outpatient, you can reduce that outpatient and only have children in outpatient care who are ready for that outpatient care, which is not generally the full population. So there's a lot of different reasons to move in that direction, but Medicaid is the number one payer for mobile right now. Some states use mental health block grant dollars to support children who will not meet the criteria for Medicaid. Some states are using state general funds to cover the cost of some children because it's worth it to do that. Those are the primary payers. And there is some conversations of some states who are thinking about how do you put mobile response and stabilization into their Family First Prevention Service Act plan, right? A little complicated because it doesn't have the research base as an evidence-based practice, but because of some of the evidence that's coming out of states like New Jersey, it is worth taking a look at whether or not it is one of the services you can include in the plan.
Great, thanks. And Rick, I know that Ohio is just kind of beginning this journey related to MRSS and Medicaid. Is there anything that you can comment on at this point in terms of that work? I know that the director of the Department of Medicaid, Maureen Corcoran, gave a webinar a week or so ago and had some very clear language around MRSS and its inclusion in Ohio's revised Medicaid plan, which I think is called Ohio Rise. Any thoughts about that?
Yeah, Patrick. You know, I think there's, I feel very fortunate, and I'll tell you why. Usually when you get a very large grant, like a SAMHSA grant, you're always wondering, will that thing that you created continue? And I've been a part of a few SAMHSA grants where we struggled and some things continued and some things didn't. I have to give a lot of credit to the state and their leadership in creating not only Ohio Rise, but really the governor's initiative around creating a crisis continuum for kids and adults, and emphasizing the importance of that. So it's not just a Medicaid initiative. However, having said that, they are also putting in the foundation at the Department of Medicaid for Medicaid reimbursable, very specifically labeled mobile response stabilization service. So we're very excited about that. We don't know much more about it. We do know that they are wanting this to be a statewide service. So, you know, we'll see as more information comes out.
Mm-hmm.
I'm sure it will present quite an implementation challenge. So we'll refer to the podcast and see what nuggets we can pull from Chris, Liz, and Jeff.
Sure.
Moving forward.
Great, thanks. I'm kind of being mindful of our time, but we have a few more areas I think it'd be good to touch on. We know that, and Liz, you just commented on the Family First connection, which has a pretty high bar for evidence-based practices and for services that they're willing to include on their list. So I think it would be important to talk a little bit about the area of outcomes and what data there is out there, or what direction you're taking that in terms of collecting more evidence. And Jeff, I'm wondering if you could, you know, share with us a little bit about where that part of the journey is.
Yeah, it's a great question. I happen to think I'm going to go back in time now 30 minutes when you were talking about implementation and challenges, but I would say that one of the great solutions out there to addressing implementation challenges of a number of varieties would be having a good data system behind you. And I think the investment that you can make at the outset of launching an MRSS initiative around having a good data system that can answer critical questions for implementation of MRSS is a wise investment. That has certainly been our experience in Connecticut, and I know it has been in New Jersey and wrap around Milwaukee as well. Rather than kind of going into excessive amounts of detail about particular data elements, I'll just highlight a few things that I think really important to pay attention to when it comes to data elements that you want to have, performance measures that you want to invest in being able to track over time. Certainly you want to be able to track very closely the number of calls that are coming into your system and the number of episodes of care that are being delivered for your mobile. That's kind of a given. But it's helpful to be able to break that down, those numbers down, to look at what those episodes look like relative to the population of children that are being served in a geographic area. It's my understanding is that Ohio is moving in the direction of creating regional areas where maybe across counties that will be served. And so knowing the population of children in a 4-county catchment area and being able to kind of index the number of episodes of care against the population of children is a helpful way to be able to standardize utilization of the service. Of course, you want to collect socio-demographic characteristics, and I'll just highlight an example in Connecticut. Mobile response was one of only a couple of services in our state where we actually saw an overutilization by children of color relative to their white peers. In other parts of the behavioral health system, particularly the deeper you get into the children's behavioral health system, the whiter it tends to look. And mobile is very different than that, or at least it has been in Connecticut, and I think it is in other states as well, where children of color are disproportionately overrepresented in the system. And by and large, we can consider that to be a good thing, because when you think about the alternatives to mobile that young children of color might find themselves in vis-a-vis the juvenile justice system, we believe that engaging children in a family strengthening and response service like MRSS is a really positive development, because it helps to prevent kids from getting into other parts of the system where you really don't want any child to be involved if you can avoid it. So collecting sociodemographic characteristics like age and sex, gender, race, ethnicity, language are all important things to be able to include as well. Couple of other things I would highlight just by way of performance measures. We've talked a lot about what in an ideal setting you want your mobile response service system to be doing. And one thing that we collect and report on routinely in our system in Connecticut is mobility rates, where we look at the number of referrals that came in and how many had a response recommendation for a mobile visit. And then we look at the actual number that received a mobile visit. And by dividing the one against the other, you can come up with a mobility rate. And as I mentioned earlier, the benchmark we've established in our state is that we want our providers to be going out mobile at least 90% of the time. Mm-hmm. And one other thing to note would be response times. And it's common for states to select a benchmark for how quickly they want mobile responders to be able to appear on site. In our state, it's 45 minutes. In other states, it's 60 minutes. And so that's something that you want to be able to track as well. And then, of course, collecting pre-post measures on clinical outcomes for kids who use the MRSS system, and then being able to link your data in ways that allow you to examine cost effectiveness and whether you've actually reduced emergency department or inpatient visitation, inpatient hospitalization rates, or foster care placements or placement disruptions, and other things that can be important to collect as well.
Great, thanks. Chris or Liz, any other comments related to the outcomes piece or the data piece?
Yeah, I really appreciate what Jeff said, and that, for your stakeholders, your decision makers, and your funders, you've got to be able to demonstrate that effectiveness data. So without question, that's essential. What I've been talking about for a while now is something that Jeff alluded to toward the end, is just effectiveness, family satisfaction. I know in Ohio, what we call interviews are becoming more important and highlighted in terms of how did the family receive the strategy and the support? Did they respond to it? Did they appreciate it? Would they refer the team to somebody else? Those things are vital. So I'm on the ground. My colleagues are 30,000 feet. My feet are on the street, so I'm much more comfortable in the home, on the corner, on the curbside, talking to a kid. But I can see that some of the developments I think we need to attend to have to do with, is this effective? In Milwaukee, we got started because we made a huge impact on inpatient hospitalization. We rerouted resources, created a system of care. And so, after all these years of working with different teams, I can see what makes a difference with a family in the moment. So some of the outcome measures that I think about all the time are family-based, but also with respect to training staff and preparing staff. We have to have some outcome measures around staff stability, staff ability, staff effectiveness, that kind of thing, that I think have been sort of relegated to, can you check this box? Did you take the trauma-informed seminar? Did you read this book? Yes, yes, yes. Well, then you're good to go. There's a vast difference between what HR wants in an MRSS staff provider and what really is helpful and effective, that we really don't measure too much, and we really don't gauge the outcome of in the staff preparedness around. HR wants someone with a flexible schedule, someone who is trained in diversity. Of course, that's important, but how can you ever really say that you are? And are you ever competent in that? Those are some of the HR things. Do they have credentials in child protective laws in their particular state or jurisdiction? What I look for is someone who exudes hope, someone with optimism, someone who has the capacity to learn and to listen and to demonstrate empathy. Those kinds of skills are ones that we really don't assess too closely in staff. We just assume because they went to school and they have a credentialing or a licensing that they can do these things. But I'll tell you, after just thousands and thousands and thousands of interventions and coaching opportunities, it's an area we've really got to help staff develop if we want to get to the next highest advanced level of being effective with families in the moment.
Yeah, great comments. Liz, anything to add to that?
Yeah, I was just going to add one quick comment or thought, and that is, for a lot of the families who touch on MRSS, this is their first touch on the mental health system, right? This is the first touch. And so it's so important that we get that part right, right? And that we demonstrate that the system is responsive and that it is worthy system for folks to come back to. So we're going to make sure that we get the right thing in at the right time for the right duration. And that part is really complicated and difficult. But to Jeff's point, we want to measure those things and know when we get it right and how we get it right. But for most families, this is the first touch. And if we say we're going to come and we're going to help, it makes a huge difference in the long term.
Great. We're gliding towards the conclusion of this really great conversation. What I'd ask you to do randomly, if you had one key lesson learned from each of your perspectives related to MRSS that you'd want to include on this conversation, what would that be? What would be the, I'm not saying it's necessarily the most important or should be at the top of the list, but something that's really key to you that's evolved from your experience with MRSS. Anybody want to venture first?
I'll kick it off. And Liz alluded to this earlier. The primary thing that I want people to begin to incorporate and engage and embed within their MRSS programs going forward is that kids are different than adults. And the shorter they are, the more different from an adult that they are. So we can't use just simple adult traditional outpatient psychotherapy strategies with these kids. And it's in every MRSS implementation protocol that I've ever looked at across the country that staff have to be versed in cognitive behavioral therapy or motivational interviewing. I talked to a 7-year-old girl who was in the throes of a psychotic episode about a month ago, and she really didn't catch on to the provider's efforts at cognitive behavioral therapy. Kids need different strategies, and they need full engagement of the family. So you can't just be kid specific and try to help a child. You've got to include the family in the plan, and you've got to use strategies that are more sensory motor, more motoric, developmentally tailored to a kid. You can't just sit a kid down at a table and have a Dr. Phil moment with them where you're having a conversation back and forth and all of a sudden there's a breakthrough and an insight and somebody gets better. Right. It's far more opportunistic than that, challenging than that. Rich in the ways that you can interact with a child therapeutically. And it's not an adult model. And that's what I want teams and MRSS systems and stakeholders to embrace. You've got to use kid-specific and family-specific strategies.
Okay, great. Okay, who's next? Who wants to?
Liz, do you want to go next, or?
Sure. I think for me, it's about taking the word crisis out of all of this. If we leave it to the adults to define crisis, then we wait way too long to intercede with children, in particular the professionals who, are really looking for outward signs of behavioral changes so that we can meet the diagnostic criteria and all that good stuff. I would say don't worry about the diagnosis. It's an important part of the conversation, but it's not the most important part, right? The most important part is that a family has said something's really going on and I don't know what it is. And our job as helpers is to help them figure it out.
Great. Chris? Jeff?
Yeah, I agree with both what Chris and Liz both had to say, but I would, I guess when you asked the question, which was a surprise question, I wrote down the word access. And when I think about some of the decisions that we made in an early stage with our mobile system in Connecticut, it had to do with breaking down barriers. The reality is that there's too many kids who have behavioral health needs who never make it into the behavioral health treatment system, even though they would benefit from being there. And for me, one of the key features of mobile response is about access. The reason that we developed a call center for the state where you could reach mobile by calling one number in the state, anywhere in the state, the reason that we talked about the just go mentality, the reason that we implemented the crisis defined by caller, the way that we set it up to be free of charge, regardless of system involvement or insurance type or your ability to pay, the reason we track mobility rates and response times, it's all about access. We want mobile response to be available to kids when they need it, in the time and place that they need it. And I think if you remain focused on that goal for mobile response, you'll find yourself in a good place.
Hi, Patrick.
Hi, Rick.
So I'm thinking of all of these very wise lessons learned, and I'm going to give you more of a developmental lesson learned. And I think what we're trying to get to is this whole idea of, for lack of better words, catch and release. So how do we get them? And then how do we do the right amount of stabilization before moving on and not be the forever service? So if we do this well, the families will love us. The problem then becomes, how do we leave? And we're only there for a very short period of time. So you want to engage, but not engage so much that they only rely on you. So.
Okay.
I leaned over. Rick, can you see that? You're not a therapist, you're a foster therapist.
Oh, that's
Catch
great.
and release. Yeah.
You're going to
It's a concept and it's important. Yeah.
Great. Well, I certainly want to thank all of you for this conversation. It's really encouraging, gratifying to know that such smart and caring people are so focused on the kids in our communities. Rick, I would say kudos to you for engaging 3 incredible resources as Ohio moves forward with its MRSS planning. So thank you for that. And like I said, we are going to have a part 2 to this discussion that will focus on Ohio-specific issues as they emerge. So folks should stay tuned to that. It'll be posted on the website as well. So just want to say thanks to each of you for taking the time and for investing your energy into this endeavor. It's much appreciated. So thank you.